Hi, everyone. Good morning. Really excited for all of you to join us today. Welcome to the New York Mobile Integrated Healthcare Web Conference 2020. As you all know, we had hoped to have an in-person conference. We put together an all-day session of fantastic speakers, and we still hope to have the in-person conference later this year. But for now, we thought since we had such great speakers lined up, we would be able to kind of put together a small sample, a taster, an appetizer, if you will, of the New York Mobile Integrated Healthcare Conference. So we thought we'd put together this webinar for you today, and we're really pleased to have all of you here with us. So thank you again for joining us. We'd like to take a minute to thank all of our sponsors who have stuck with us through this change of plans. So we are hosting this webinar today thanks to the support of all of our sponsors, Ambulon, Senior Care, General Devices, Portola, and ImageTrend. So a huge big thank you to all of them for sticking with us. And we do hope to have the in-person conference later this year. And I hope that all of you will help to support our sponsors. A little bit of housekeeping. There is a Q&A section in your Zoom webinar feature. So we'll be using that throughout the day. So if you do want to ask questions of the speakers, they may or may not be able to see it while they're speaking to you, but at the end of their talk, if time allows, we will include, we will try to ask a couple of questions from the audience. There will also be a question and answer session later in the day. I always like to start these sessions with a little bit of a primer, talking about where we've been and how we've gotten to where we are today. And so, we've spent the last decade or more talking about how EMS can and should be doing more to be more integrated into the healthcare system. This visionary document from 1996 with the EMS Agenda for the Future stated that EMS will be community health management that is fully integrated into the overall healthcare system. We've put out many other papers, position statements, and more talking about this future where we're recognized as a community-based resource and can provide more than simply transportation. We've argued and we've pleaded and we've told everyone that would listen that EMS is uniquely positioned to help patients and communities. We're available in every community. We're fully mobile. We can address patient needs 24 hours a day, 7 days a week, 365 days a year. And we're an expected, respected, and welcome source of medical assessment and care in people's homes throughout the nation. And, we've started to see a little bit of a movement. It took a long time, but, from governments and payers and hospitals, people are starting to recognize the incredible value that EMS is able to provide. In fact, bringing patients to the hospital is increasingly recognized as, perhaps not in the best interest of the patient and not necessarily in the best interest of our hospitals. It even took, our own community a little while to grapple with, putting labels, putting words on these ideas in which we could provide this sort of newer model of healthcare, redefine who we are. A handful of years ago, our community, our EMS community came together and came up with a common definition that I think still holds pretty good. It's the provision of healthcare using patient-centered mobile resources in the out-of-hospital environment. And the movement is growing around the nation. We have programs in nearly every state, providing a variety of unique programs. This movement is simultaneously local while it is also national. We learn from each other, from state to state, from community to community, but yet in the local area, we fill gaps and assess needs and try to design programs that make sense in our local communities to best fit the needs of our patients. I'm proud that here in New York, we have a number of community paramedicine programs up and running. Last year, we were able to feature all 7 of the NIMH programs in New York State, and with the caveat that we were aware of. And I'm proud that over the last year, we've learned of 2 new programs. We're proud to welcome New York Presbyterian, their community paramedicine program into the fold, as well as Monroe Ambulance up in Rochester. So fantastic, and kudos to all of these programs here in New York State. Many programs around the country have been able to demonstrate that their models of care provide significant benefits to patients, significant cost reductions, and improvements in quality of care. Mount Sinai was fortunately to be recognized by the Wall Street Journal for its savings. Some of the most impressive programs, probably the largest scale and federally supported program in EMS innovation was the CMMI Healthcare Innovation Award granted to REMSA in Reno, Nevada. They showed enormous savings in all 3 of their interventions: a community health intervention, a nurse helpline, and a alternative destination program. We are so blessed to have Brenda Staffan with us today, who was the director or one of the leaders of this program in REMSA. And she's now actually part of the ET3 model, the ET3 model team at CMMI. So it's like we have our own inside woman. So glad to have Brenda today. Another fantastic program that I think has been hugely influential on policy, on legislators, on everyone, was the program in Houston, Project Ethan. This was a telemedicine initiative, which showed that if you put telehealth in the hands of EMS, the combination is powerful. They were able to demonstrate reduction in costs, reduction in ambulance transports, and significant savings in time and resources for the EMS agency. As all these programs have continuously shown improvement and developed, we still get this issue with, we become increasingly frustrated, and it's become increasingly obvious to all parties, including the payers themselves, that we need to fix EMS reimbursement policy. As you know, payment is almost inextricably linked to transportation. I noticed that there's not an equal sign there. There's 3 bars, because that is not an equal sign. That is a triple covalent chemical bond. And we spent a lot of time trying to lyse that bond. And so hopefully we can make some progress. 20 or so years after the first EMS agenda for the future, another EMS agenda document came out describing a really beautiful vision for a people-centered vision for the future of emergency medical services, one in which EMS is adaptable and innovative, sustainable and efficient, integrated and seamless, reliable, prepared, socially equitable, sustainable and efficient. I'm really proud of this document. I think it really shows a great future for EMS. But one of the things that many people would mutter or whisper was, well, this is great, but how are we going to pay for this? Particularly so long as we're just being paid for transportation. So while we were sort of releasing this document and struggling with that question, seemingly overnight, obviously it took a lot of work from a lot of people over a number of years, but relatively quickly, this issue rose to the top of CMMI's list of opportunities. And it was actually Valentine's Day last year that CMS announced the ET3 program, Emergency Triage, Treat, and Transport. Basically, it's a new alternative payment model. You can hear a lot more about this today. So, and many of you probably already know a whole lot about this. I won't delve too much into that. It allows us to do alternative destinations and be reimbursed for it. It allows us to do telehealth with EMS, and both the provider and the EMS agency can be reimbursed. Here in New York City, it really actually spawned a really nice regional collaboration where the entire New York City 911 EMS system, which is actually supplied by a number of agencies, all collaboratively applied as a region. So sort of unprecedented amount of collaboration. And it was just less than a month ago that CMS formally announced that they had selected 205 applicants for the ET3 model. So things were looking pretty well. New York City, all of our agencies were accepted. And so, things were looking pretty well for the, moving forward in this direction about a month ago. Then, I think our entire society has kind of turned upside down a little bit. The world as we know it is, I think, forever changed. The coronavirus has exposed deep holes in our nation's preparedness to deal with emerging infectious diseases. And on the front lines of this global pandemic are our brave EMS providers. They're out there putting their lives on the line, battling this disease, along with our emergency physicians and other nurses and all the other emergency care workers in our health system. So on behalf of the New York Mobile Integrated Healthcare Association, I want to thank all of you who are involved in EMS, particularly those that are on the front lines. It's obviously frustrating that some of our agencies, some of our providers are having to beg, borrow, and steal to get the PPE they need to keep themselves safe in the field. We wish you all well. For those frontline providers that are able to join us today, thank you so much. And of course, we want to make sure that, at least for New York City providers, we can provide you with some RE/MAX CME credit. We thank you for your interest. Interestingly, it's in this moment that it's never been more painfully obvious that EMS is more than a transport system. We need to be recognized that we do more than take patients from point A to point B, that we are part of the healthcare system, we are part of the house of medicine. And that house has never been under more strain than it is today. The incredible workforce, the whole EMS community must be allowed to provide the full scope of care that we are capable of. So today, that brings us to our conference today. We'll hear from a number of incredible speakers who will share with us their experiences, their perspectives, their visions for what EMS can be doing right now, should be doing right now, and also in the near future, hopefully in a post-COVID world. So with that, I want to thank you all for joining us. Thanks again to our sponsors. And we're going to begin our conference today. Our first speaker is Dr. Brent Myers. Dr. Brent Myers is one of my, I think, heroes in emergency medicine. He has had a long and successful career. Notably, he was the medical director for Wake County, one of the premier EMS systems, where he did incredible work on cardiac arrest research and alternative destinations work. I think he was one of the, they had one of the first programs with advanced practice paramedics in the field. He then was chief medical officer for Evolution Health, which was sort of almost like a sort of national scale mobile integrated healthcare program. And now he's the CMO for ESO Solutions, one of the premier data systems, PCR platforms in our industry. So we are really pleased to have Dr. Myers with us. Thank you for all that you do. Thank you for being with us today under these significant circumstances. We're really glad to have you. Thank you so much, Dr. Myers. I'll turn it over to you.
Thanks, Kevin, for that great introduction. And hello from my home office here in Raleigh. I'm going to share a screen here, and just so we can see the presentation. Give me just 1 second. There we are. Can y'all see the screen okay?
I don't see your screen yet.
Okay, let me try again.
Yeah, we see your screen now.
Okay. And the PowerPoint should pop up now. There we are. Are we better now? Okay,
Yeah.
great.
Yeah.
Well, thanks everyone, and thanks for allowing me to join this great conference. And I do look forward to a trip to New York at some point in the future. I would like to begin with a couple of reflections. And to build on what Kevin said, we are in a different time. And I think we focus on the complications that we may be having with PPE and surges of patients and trying to determine how to route patients. And indeed, we'll talk about that over the next few minutes. That being said, we also should remember there are challenges across our society. And while we have challenges in general, they do not relate to having a paycheck during this crisis, whereas our friends across multiple other industries are not only dealing with the stresses of being at home and am I infected and all of that, but also worried about income and paychecks and so forth. So the society is under a strain, and we can't really move forward without at least acknowledging that. That being said, I think it's also important to reflect on this slide and think about the difference of a citizen when they call 911 versus almost every other healthcare decision that they make. In other words, even from Medicaid to Medicare to private pay, most patients have a choice. It may be a narrow choice or a wider choice, depending on where you are in the country, but rarely do you have a single physician that you must choose. You almost always have a choice. Just like you historically had a choice in airlines, and I'm quite confident at some point we will again. That being said, when you call 911, you have no choice. And so to Kevin's point, we have a tremendous opportunity, but with that opportunity comes a tremendous obligation to make sure we get this right, because our patients are putting their trust in us, and they really only have us as the choice in any individual community. So what I'd like to do briefly is lay out a roadmap, if you will, to bring us into the changing healthcare environment. And we're going to spend just a brief period of time on historical measures, if for no other reason, to help us not make the same mistakes again going forward. I'm going to argue that there are already examples where we have focused clinically, and when we have done so, we've brought ourselves further into the house of medicine. We have the world's expert on ET3 to speak later, so I'm going to speak to that briefly, only to introduce how it may be accelerated in the current environment, and then we'll have some, hopefully, time for discussion at the end. So the historical measures of performance, unfortunately, have been time matters, and I would encourage us as we go forward and think about how to integrate into the healthcare system that we avoid measures like this. And the reasons are a couple. The first is the temptation to measure time was there simply because it was easy to measure. And perhaps we should not be measuring something simply because it's easy. And secondly, it was based on a questionable interpretation of a paper. And this goes all the way back to 1984. But this paper was published to ask and answer a single question, which is, at what point in ambulance response time does adding first response confer benefit? Let me say that one more time. At what point in ambulance response time does adding first response confer benefit? So if an ambulance arrived in 2 minutes, I think all could agree it's highly unlikely that adding first response would add any particular benefit. But is it at 3 minutes or 5 minutes or 8 minutes, or where is it? And as it turns out, it's at 8 minutes and 59 seconds. But that doesn't have anything to do with the patient outcome. Indeed, if you have robust first response, the response time of that ambulance was not studied in this paper. But from this came the industry to say, in 8 minutes and 59 seconds, you must be there, or you are not a good EMS agency. And so this is a paper that had a very important question, but became misinterpreted and allowed us to chase the wrong thing. And I'm going to encourage us not to do that, because as a matter of fact, as we all know, moving to resuscitate someone from cardiac arrest, if that's our point of interest, requires a response time of 4 minutes or less. Certainly not 7, 8, 9, 10, 11. The curve is flat for survival once you're that far out. So it's easy for us to get on the wrong track as we're trying to find some measure to move us into the house of medicine. There are a host of others, and we'll come to those. But the notion is, let's measure something that matters rather than measure something that's easy. So that's kind of hopefully take home point number one, is that as we enter into this new healthcare environment, we're going to measure what matters. The second is through the lens of trauma. I want to argue that Kevin had a great point that we have been discussing this, some of us on this call, for more than a decade. And this notion that we can't do it, that EMS can't enter into the House of Medicine. We're just a transport agency. We've got a blueprint of how to do that, separate and aside from ET3, which is a great success. But within the House of Medicine, there was this notion of backboards. And backboards came to us in almost the exact same way that response time did. It was a singular paper back in 1967, and I apologize for the graphics, but this one is no longer electronic, so I had to get an image of the best image I could of this paper. But this paper described a single patient who ran off a road in a rural community and had a spinal injury. And then there was the hypothesis that if there had been a backboard and immobilization in the field, it may have helped. And from this description of how to immobilize a single patient came the backboard phenomenon, if you will. But there was a path in the past 3 years that shows how we at EMS can change the standard of care. And if we can do it with backboards, we can do it in a mobile integrated healthcare environment. And this roadmap is important. This roadmap included the American College of Surgeons Committee on Trauma, the American College of Emergency Physicians, and NAMSP. Well and good. But 12 other entities signed off on this paper, from the International Association of Fire Chiefs, the International Association of Firefighters, to NAEMT, the whole list of EMS entities across the United States signed off. So the point being, it took 2 years, 30 revisions to write a 2.5-page paper. But that paper changed the standard of care because we took the time to get everyone together, get agreement, and move forward. This paper is the most downloaded paper in all of Taylor and Francis medical publications, not in EMS, not in emergency medicine, in all of the House of Medicine for which Taylor and Francis has publications. This is the most downloaded paper. So that tells us that we can get the attention of the entire medical community and that we can change care. So it's not that we can't do it. The other piece comes to, can we get creative? And can we actually take blood? And I don't know how many of you work in a hospital, but trust me, the blood bank has a, shall we say, regimented philosophy, which they should. But to do something different with whole blood, to take whole blood out of a blood bank and put it in a cooler in an ambulance for 2 weeks, people would have said that's preposterous. There's no way that can be done. Well, as a matter of fact, when you take evidence, which came from our military colleagues, and demonstrates that if you transfuse whole blood in less than 15 minutes after injury, your probability of death plummets, and we challenge our community, we too can do this. This is happening across the United States now. Blood banks are indeed putting blood in the back of an ambulance. They are indeed allowing that to rotate through the system. And we actually now have our friends in San Antonio have a complete program, some by air, some by SUV, some by ambulance. They have a list of how this can be done. And so I'm not purporting that mobile integrated health or community paramedicine should necessarily be administering blood. But my point being, if we can change the standard of care with the American College of Surgeons around backboards, if we can convince those folks in the blood bank that EMS can safely and assuredly move things through the healthcare system and preserve blood, and in all of these systems, from Seattle, King County through San Antonio, through others that are doing this, there's been no wastage of blood. We have proven that we are responsible components of the healthcare system. Then surely to goodness, we can do things like obtain a lab, do a telemedicine visit, and be safe with that if we can do these things. I want to shift gears for just a moment to talk about the recent measures of performance and truly congratulate those that have been working with NMSQA and the Compass measures too. These measures are very similar to what we see throughout the healthcare system. And the notion here is that we're growing up and we're demonstrating that we can measure just like hospitals do. And that things like using lights and sirens and putting the public at risk, we can measure those, and we're willing to be introspective. So I think this also gives us a roadmap for metrics that we can use in the mobile integrated environment to prove our worth, not only from a fiscal perspective, but also from a clinical perspective. So I think that this is also a very nice roadmap for us. And we would be remiss today if we didn't talk a little bit about COVID-19 and infectious disease. This notion that EMS can't enter into this space, I also would like to challenge. The notion that we can't monitor flu, and this is just a simple graph of EMS across the country having impressions of influenza-like illness. And as it turns out, this leads the CDC by about 2 weeks in any given direction. So we at EMS can also contribute to that and again, be part of this future of the healthcare environment by providing useful, actionable, meaningful data. And just in the past 2 weeks, we have demonstrated across the country as EMS our ability to appropriately document, use PPE, and encounter patients that are potential and or confirmed COVID-19 patients. And so we've proven our ability to adapt and move and overcome. I'm not going to go into the details of ET3 because I know we're going to do that going forward. It was Valentine's Day a year ago, so we're in that anniversary, just post-anniversary phrase. We know the reasons for doing it, and we know the key components. And I think if we think about getting position papers with large groups across the country, we think about our ability to do things creative like move blood into the field, and we then start thinking about what can we do in these spheres, it becomes very, very easy for us to think about ways to make ET3 our moment of success. And finally, this is just Florida's, but there's so many of these that are really taking ET3 and applying it to COVID. You will see that there's the notion of, are we going to a different site? Are we treating on scene? How will we do that? And this goes on for several pages that's beyond the time that we have here, but the notion is the protocol says, these are the people that it's safe to leave behind. These are the people that need to go to telemedicine. These are the people that may need to go to alternative destination, which is fascinating and hopefully a sign that the ET3 notion is permeating the community and not simply in the pilot project. I halfway jokingly talk about how difficult it is not to have NCAA basketball in North Carolina and how much I'm going to miss sports. So I'm going to end with a sports analogy. And I think it is apropos for how we have moved for this notion of mobile integrated health and community paramedicine. There's kind of two measures that people use, and there's baseball statistics that we can argue their relevance all the time. But one of the statistics is, what is your time of possession per drive in the NFL? And that's a scatter plot about whether you're going to win or not, right? That really doesn't seem to have a whole lot to do with anything. However, if you look at the time of possession per game, there's a linear relationship between who's going to win and who held the ball the most during the game. So for those of us doing this a long time, we've had a lot of 3 and outs. We've lost a lot of yards on various plays. But I think over the long haul, we're now at the point where we've held the ball long enough for the whole game that ET3 is getting ready to be our clarion call, if you will, to then be able to demonstrate our value with everything that's around it. So I think we're ready to enter the house of medicine. I think we've proven our value. We should not waste this crisis, and I don't mean to take advantage of it, but I mean that for us to appropriately respond to the current COVID crisis, we have to be able to use telemedicine and to not transport everyone to hospital. And we should responsibly measure that so that it can be reported later and bring us further into the house of medicine. And I cannot thank everyone enough, Brenda and everyone related to ET3. This is our ability to demonstrate entering into the house of medicine. And it's been handed to us on a silver platter, and shame on us if we don't take advantage of it. So thank you very much for having me. That's kind of the condensed opening comments with, I think I've still got 17 seconds to be under time, Kevin. So you told me 15, and I think that's 14:48. So thanks, and happy to be here.
Well, thank you so much. That was fantastic. I love the sports analogies. I think I wanted to just ask you one quick question, if you don't mind. ESO is known for having, really fantastic back-end data. Are you guys seeing any trends in light of this crisis? Beyond the flu graph was excellent. Are you seeing more transports? Are you seeing reduced use of nebs? What else can we learn from looking at sort of the big picture across the nation?
Yeah, so we're seeing three things to really talk about. The first is that overall call volume is down. We can't tell if it's 10 or 15%, but it's not 2%. So 911 call volume is dramatically down. The use of personal protective equipment, particularly eye protection and N95, is 2, 3, 4, 8 times higher just in the past week than it was in previous weeks. So just like in the emergency department, we know that there's a tremendous increase in utilization of PPE, and that's going to run through supplies. And then finally, we haven't seen the neb change as much, but we have seen a decrease in utilization of endotracheal tube, and we've seen people move to a drug-facilitated eye gel or a drug-facilitated king and that type of thing, small n, but we hadn't seen that much before at all. So it's a change in practice from that perspective.
Very interesting, fantastic. And Brent, you're going to stick around so we can ask questions during the Q&A session, correct?
Sure.
All right, fantastic. All right. Again, reminder to everyone to please, send in questions through the Q&A. All right, we're gonna try to stay on time here, so we're gonna turn it over to our next speaker, Brenda Staffan, who is a senior advisor for the Center for Medicare and Medicaid Innovation. Brenda was the Chief Operating Officer of Integrated Services at REMSA, the Regional Emergency Medical Services Agency in Reno, Nevada. This was the agency I referenced briefly earlier that received a Healthcare Innovation Award, I think it was back in 2012. And over the next 4 years, actually, they demonstrated an incredible amount of savings. It was extraordinarily well executed, and perhaps one of the rare programs that actually put out all of its results and shared that with everyone. So we're really impressed with that work, and we all feel that work was integral into leading to the ET3 model, and perhaps CMMI felt that way too because they went and hired her. And so we're really grateful for Brenda to be here with us today. One of the smartest women in EMS. So thank you for joining us, and we're looking forward to hearing your words today.
Good morning. Thank you, Kevin. And good morning to everybody. One moment while I switch over my slides. Great. Is my slide number 1 up?
Yeah, we can see it. Yeah, we can see it.
Okay, and sound check, can you hear me okay?
Yes, Brenda, perfect.
Excellent. Thank you again. Thank you, Kevin, for inviting the Center for Medicare and Medicaid Innovation to participate in your conference today. I'd also like to recognize some of my colleagues that are on the call today with me. Janelle Gingold is our division director, and Alice Thompson, our deputy director. Carly Bird is our ET3 model team lead, and Adam Obest handles our communications and stakeholder engagement. So thank you also for our CMMI colleagues for joining us today. So Dr. Myers provided a great introduction, and Dr. Manjal as well, about the environment that we are working in, where we've come from, and then the future, what is our future state? And so as has been indicated on Valentine's Day, just over a year ago, the Secretary of Health and Human Services, our CMS administrator, and the the CMMI Center director announced the ET3 model. And the goal of the ET3 model is to really begin to realign the incentives to create that future state that, that so many in our healthcare sector know is possible. So the ET3 model has 3 interventions. And I'm going to briefly provide an overview of what those 3 interventions are, but more importantly, I'm going to give a little bit of more detail about where we are currently in the model. The ET3 model interventions include ambulance transport to alternative destination sites, which can include urgent care centers, physician offices, behavioral health centers, and other medical facilities that are appropriate to receive patients. The ET3 model also includes a new intervention called treatment in place. Treatment in place can occur either on site with a qualified healthcare practitioner or via telehealth, 2-way communication and video. So these 2 interventions were covered by a request for application, which was issued last year. There's a 3rd intervention that covers medical triage line. And soon there will be a notice of funding opportunity released, which will provide funding to establish new or to expand existing medical triage lines. So there's a few new terms that we reference in these models sponsored by the CMS Innovation Center. So when we refer to participants, we're talking about ambulance suppliers and providers. They must be Medicare enrolled, and as I mentioned before, there are 2 interventions that they will be providing: alternative destination transports and then treatment in place. The other type of ET3 model entity are awardees. They will receive cooperative agreements, and those entities will be establishing medical triage lines for low acuity calls received via the 911 center. I'm going to spend a little bit more time on this slide because partnerships and building relationships is a key element of the success of the ET3 model. The Medicare enrolled ambulance suppliers and providers, through the request for application that they all responded to, were required to establish partners. Those partners are the alternative destination sites that will receive participants. The alternative destination intervention was required as a part of ET3 participation. The treatment in place intervention includes partners that are optional. The treatment in place intervention itself was optional, and those partners will be, as I mentioned, providers of healthcare services, qualified healthcare practitioners that include entities like physicians, physician assistants, and nurse practitioners. They will provide in-person treatment on the scene. So for example, if those entities are on the ambulance with the ambulance crews or via telehealth. So the Medicare enrolled ambulance suppliers and providers will create agreements with these partners to implement the ET3 model. Those agreements will have various requirements related to data, related to compliance, and related to participation in the model. There are other very strongly recommended relationships. The first and foremost is non-Medicare payers. The model highly recommends a multi-payer strategy so that the funding mechanisms that are provided by the ET3 model, ambulance payments, and I'll go over those in a moment, are supported also by commercial insurers and state Medicaid programs. So there will be a significant amount of work in the ET3 model associated with building out that multi-payer alignment, involving not only participants, but also support from our learning system, which I'll also describe later. The other relationships that are recommended are with public safety answering points, and that comes through with the medical triage intervention. So again, just to emphasize, because our health system is so integrated, and especially the emergency medical services or the emergency healthcare services that are provided, these relationships are extremely important. So as we've noted, ET3 was announced on February 27th. The applications portal opened in August and closed in October. And just in February, we announced selected applicants, and there were 205 ambulance suppliers and providers from 36 states, as well as the District of Columbia, that were announced as selected applicants. These organizations are quite diverse, and it's very exciting to see the diversity in the types of organizations. All provider types were represented. So there are government-owned applicants, fire-based, private nonprofit, private for-profit, and hospital-based. In fact, you can look at the actual list of selected applicants on the ET3 website. We do have a large representation among regions, and we also have some applicants from rural services as well. So here's a map of where our participants are located, and as Dr. Munjal pointed out, there were a few places where regions came together and submitted, collaborated and submitted a coordinated application. The states that have the largest number of applicants do include New York and California and Texas, and you can see that represented in the map. You can also see a lot of applicants in Colorado, and then up in the upper Midwest in Minnesota. So it's very exciting to see the diversity of provider types, how many regions are represented across the United States. Again, coverage in both rural and urban areas. We do have applicants in Hawaii, and as you can see on the map as well. So again, 36 states are represented in our applicant pool. So as I indicated originally, the purpose of ET3 is to realign the incentives and to provide new payments under the ET3 model, which will build on Medicare's existing fee-for-service structure. So the payments that are described in this slide are for Medicare fee-for-service beneficiaries. So the payment model for the alternative destination transport component provides base rate payment based on the level of service provided following existing Medicare regulations. So that can either be at the BLS emergency or ALS 1 emergency rate. And mileage and applicable adjustments will follow the existing Medicare ambulance fee schedule regulations. So payment for transport to alternative destination basically mirrors existing Medicare reimbursement. So payment for treatment in place, in person or via telehealth, also mirrors the current Medicare ambulance fee schedule. And ambulance suppliers will receive reimbursement based on the level of service provided once again, and they will receive a base rate payment at the BLS emergency or ALS 1 emergency rate based on existing Medicare regulations and definitions. They will not be receiving mileage, obviously, because a treatment in place intervention does not include transporting the patient to a facility. Then the qualified healthcare practitioners will be also paid based on the current Medicare fee-for-service rate. So the ET3 model is facilitating payment of those entities through the existing telehealth regulations. There are 2 additional payment adjustments that the model will implement. The first is the qualified healthcare practitioners which provide care after hours which is defined as 8 p.m. to 8 a.m., will receive a 15% increase for those services. And those calculations will be done as a part of the payment operations process. Then ambulance services will receive a performance-based payment adjustment for achievement of key quality measures, and that adjustment will be up to 5%. This performance-based payment adjustment is not guaranteed. The center is working on developing what this payment adjustment is based on, and it will occur no sooner than year 3 of the model. So I just want to emphasize this payment adjustment will happen in year 3 and is not a guaranteed item. So I've mentioned a little bit about our timelines. As we all know, the selected participants for the first 2 interventions, alternative destination, transport, and treatment in place, were announced on February 27th. The participants are going through a process of reviewing their participant agreements, which is the document that they must sign to actually participate in the model. The current date for model go live is May 1st, and the notice of funding opportunity for the 3rd intervention, which is the medical triage intervention, will be published soon after. And the eligibility requirements to apply for the notice of funding opportunity include that they must have, the applicant for the medical triage line must have a ET3 model participant in their coverage area. So that's the purpose of the linkage between the model go live and the publishing of the medical triage line a cooperative agreement. The funding for the medical triage line is in the form of a cooperative agreement. So that is a different type of funding, and it is more grant associated, grant-like, and detailed information about the medical triage line eligibility will be in that notice that will be issued right around model go live. I do want to emphasize the asterisk on the end of today's slide, on this last timeline side, that these dates are subject to change. We have received feedback from participants about the current state of operations related to the national emergency and the state and local declarations. And so as soon as CMS is available to provide more information to participants about all of that feedback, we will do so. So I do want to emphasize that these dates are subject to change. And so Dr. Munjal, that really concludes my overview about the ET3 model. I really want to thank you personally and of course the rest of the panelists for putting on this conference, and we thank you for the invitation to participate.
Thank you so much. That was fantastic overview. There are a couple of questions. I think if we have time for 1 or 2. The question came in from Isaac Sobel. What will medical necessity requirement look like for ET3? And if I could just kind of add to that, for example, is it different for alternative destinations versus the telehealth? And do you expect additional guidance beyond what's already been issued on that to be provided?
Great question. So I think there are 3 components of the answer. One is, as you indicated, that there will be additional guidance. Participants will receive onboarding webinars and fact sheets and additional guidance about participation in the model as the model is launched, as the model goes live. And so additional guidance will be provided to participants. In general, however, as I stated a moment ago, The reimbursement for ET3 interventions is following existing Medicare regulations. So they're following the medical necessity criteria in existing Medicare regulations are still in play. And then the third answer will be participants will be developing their own clinical protocols approved by their respective medical directors. And so those clinical protocols also will be specific to their community statutes and local regulations.
All right, thank you. There are a few other programs. On the flip side, while some are asking whether COVID would be delayed, another question is about whether COVID could be further accelerated in regards to COVID.
Right. You know, as I said, that these we have received feedback, and as soon as CMS is able to provide more information to the selected participants, we will do so. So again, we have received feedback, and so as soon as we're able to let people know, we will.
All right, thank you so much, Brenda. You know, again, we've heard from Dr. Brent Myers, who has a great national perspective, you know, from the PCR company and from his work as a medical director. We've heard from Brenda Staffan from CMI, kind of helping us understand some of the intricacies of the ET3 project. For those of you that you know, may not be that close to it, I think you know, really understanding the purpose and the federal perspective, I think, is really helpful. Now we're going to turn it over to Jonathan Washko, who you know, I think is one of the leaders in you know, EMS nationally, and certainly here in New York State. Mr. Washko is the Assistant Vice President for the Center for Emergency Medical Services at Northwell Health System. He has an MBA in Global Health Services Administration from Hofstra University. He's on the board of numerous industry associations, and you know, he's part of every major conversation in EMS that you can think of. He's a highly sought after consultant who advises on organizational improvement, technology, venture capital in the EMS sector, and has won too many awards to count. And speaking of count, I count him as a personal friend and somebody who I look to as a advisor and as somebody who can always turn to, is always very responsive. And I think that's true for almost anyone that reaches out to him. So we're really grateful to have Jonathan with us today. Jonathan can talk about probably anything, any topic in EMS, but today we've asked him to talk a little bit about the telephonic medical triage capabilities that they've developed at Northwell, and perhaps in particular, you know, how that might be leveraged in this moment of crisis here in New York City and the other areas that Northwell serves. So thank you, Jonathan, for being with us, and I'll turn it over to you.
Thanks, Kevin. Can you guys hear me okay?
Yes, I can hear you great.
Okay. Let me get my screen shared here. We're having some technical challenges here. Give me 1 second.
All right. Tell us when you're ready, Jonathan. In the meantime, we have a couple of more questions that did come in for Brenda. One question came in from Rob Lawrence. What would you say the key metrics are going to be in measuring performance and outcomes? What would be your top three? What are you looking for?
Well, because we mentioned that, because the model includes a payment bonus based on quality measures? The answer is that the most important measures are the quality measures. And so there will be a process announced to participants about what those quality measures are. And so also in the request for application, the CMMI did provide an example of what the quality measures would be in the request for application. That example included impact on ED utilization. So those are the current publicly available, I mean, those are the things that CMMI has stated about measures. And again, I want to emphasize the timing. It will take, this won't happen until model year 3.
Okay, fantastic. Jonathan, how are you doing?
I would move on to the next speaker. I'm going to unfortunately have to quit and come back in. So if we can juggle that, I'll go up next.
Okay.
Apologize.
No problem. Hanan, are you ready? I can introduce you.
Absolutely.
Okay. So I'd also like to introduce our next speaker, Hanan Cohen. He's the Director of Corporate Development and MIH Programs at Empress EMS. He's a paramedic and a community paramedic with 30 years experience in EMS and hospital administration. He has spent the past several years researching, developing, and implementing an MIHCP program at Empress EMS, providing service to patients in Westchester and New York City. And in particular, I'd like to thank Hanan for his involvement and support for New York Mobile Integrated Healthcare Association. And he is, I think, somebody who is constantly innovative, constantly finding opportunities, building relationships. And I think as a result of all his relationship building, he's actually been able to put together a program with obviously very little notice to actually help the Westchester County Department of Health in their COVID screening in the community. So, there's a million things that Hanan can talk about today, but I'm hopeful that we get to hear a little bit about that, what I was playfully referring to as mobile integrated COVID testing.
Thank you.
All right, go ahead. Are you sharing your video and your slides?
Seeing them?
Your slides now.
CMS, for those of you who don't know, operates in Westchester, New York City, provide municipal 911, interfacility, critical care, and an expanding community paramedic program. And very recently, as recently as 2 weeks ago today, we were requested to join the ever-burgeoning response to the COVID issue in Westchester, most notably which started with patient 0 in the city of New Rochelle. So on the 6th, Friday, March 6th, we had a mobilization request from DOH about 4 o'clock in the afternoon, asking us for whatever assistance would be possible at the newly to be developed incident command system in New Rochelle. We responded at 0700 on Saturday with a group of our community paramedics, 4, along with 6 other EMTs and paramedics to the site. Again, unknown what would be our purpose or the process. But the first ones that showed up, first volunteer were actually from our community paramedic corps, which we're incredibly proud of. So we arrived, found this sign, found check-in, found some parking, noticed that they had this wonderful structure in place, which we love. We're very fond of the incident command system. Realized there were a few familiar faces in the room, significant support from the New York State Department of Health Bureau of EMS, tagged as the New York State COVID-19 2020 Task Force run by the New York State Incident Management Team. Around the next corner, after we passed the rostering sign and the ICS system, we found out that it was just a little bit different as who showed up as to who was invited to the party. It was a typical first day. There was a wonderful show of allied healthcare professionals, nurses, paramedics, EMTs from across the state. Took a little bit of a while to shake out and realize what the responsibilities were going to be through a series of briefings, interactions with folks from the New York State Department of Health, Fire, Homeland Security, Emergency Services, New York State Police, Department of Environmental Conservation, Forest Rangers, CDC, and the multiple departments of health, Westchester, New York City, and most notably New York State. Obviously, the invitation for EMS to join was greatly appreciated. I'm sure no small deed due to Director Greenburg's heavy involvement and innovative ways of managing the department since he's been there. The incident objectives for the process were to provide safety of incident personnel, develop a targeted response, and to respond to the needs of basically the 5 surrounding counties, New York City, all 5 boroughs, as well as Suffolk. During that time, Nassau, predominantly Westchester and Rockland. Initially, the teams were devised of a nurse, a paramedic or an EMT, and a driver who functioned as what would be considered a crew chief, kind of a safety officer looking at the rest of us as far as appropriate PPE utilization, egress, access, and managing the actual testing supplies. Early on, we were quote unquote support staff, not professional staff, not clinicians. But round about 1 o'clock in the afternoon, this item appeared on everybody's email, which is an executive order from Governor Cuomo. It's multiple pages long, but the most important part that I'm concerned of was this part that says, to the extent necessary to permit emergency medical services, to provide community paramedicine, transport to destinations other than hospitals or healthcare facilities, telemedicine, and to facilitate treatment, et cetera, et cetera. So there's a point in time that this came out, we were technically involved in the process. During the mornings, during that first morning, we had partnered up with experienced nurses from around multiple departments of the state and did kind of a one-on-one off, learning how to do the swabbing, not a high level of interaction, but nonetheless, the most important interaction of this group of patients was swabbing them, testing them, getting the results back fast, as it was an ever expanding circle of persons under investigation. So immediately upon that, in kind of a typical EMS fashion, we became very innovative, very responsive. The Daily News took a little license with what we used to call that when we were first supervisors there. And we began being involved in the full process, whether it was the door-to-door screening where teams of 3 went out with lists of persons under investigation, or a few days later when the drive-through was stood up, we supported the staffing there based on the demand, and have continued to do so since. And instantly resting off Dr. Manjal, I shared one of your quotes from the earlier EMS agenda, that EMS of the future is community-based, and there's nothing more community-based than what is transpiring in Westchester right now, and which continues to. There have been many other agencies and associations that have slowed down on their responses, including fire and police, including some of the other visiting types of home health, and we to date obviously have done none of that. We have seen, just as been mentioned, a decrease in certain levels of response, both on the 911 and interfacility side, while altogether, ramping up with significant increases in staffing for these other projects at hand. Couple early lessons that we learned. Day 1, donning and doffing in gale force winds when it's 55-mile-an-hour winds outside, using hospital PPE in a discreet method of, as patients wanted to be, unbeknownst to their neighbors. It was learning on the fly. Day 2, we learned to beware of the top floor, that if you're going to a penthouse, your elevator will open up directly into a person's living room, and if they are standing there, welcome to 14 days of home confinement. And VIP has multiple definitions. I won't go into all of them. Use your own guesses on those, but not everybody who was a VIP was exactly appropriate with us. So we learned on the fly. The teams were very multidisciplinary, which is another part of mobile integrated healthcare. There were nurses of varying degrees of experience. There were EMTs and paramedics of varying degrees of experience, and drivers and support staff from every walk of life, every department in New York State, all thrown together at literally a moment's notice, and did a very good job shaking it off and working together, at a very high level. few of the things that had transpired was shortly after the persons of interest were being done on a one-by-one basis, there was the first hotspot in a nursing home in New York City where 3 patients had become critically ill, and they isolated a 40-patient unit along with staff and decided that a more targeted response was necessary. CDC and DOH were dispatched to the nursing home, and at that time determined that it was going to take between 2 and 3 days to complete the process of screening, which a little outside of the good morbidity and mortality rates for folks of that age and of that level of concern. So the New York State DOH sent a team down of 12. At that point in time, it was 8 nurses, 4 paramedics, and for whatever reason, maybe because I had a pretty uniform on, I was chosen to be team leader. We responded using an incident command type structure and managed to safely and effectively test the entire unit in 85 minutes. And the tests were in Albany within an hour after that. Interesting on my part is just kind of reflecting back a little bit. We understand we need PPE now. What I think in conversation, or actually it's in text conversation with a few others, we do need ET3 now. It's an existing possibility. There are waivers and authorizations and actions taking place that benefit every walk of healthcare, except for those of us who are basically doing it for free right now. And on the other side of that, we have, advanced folks with forward-thinking providers and practitioners and even payers such as Anthem using AO 998 to provide a funding source for treat and no transport. I certainly don't see from the non-political position how hard it would be to have any type of executive action order to require other payers in the state and the country to enable that code so that for this increasing number of folks that we're going to be treating and not transporting, that there's a stream of reimbursement to support the exorbitant PPE costs that are now coming. So the process has been very fluid. To date, we have been participating in testing over 1,000 people, both at the drive-through center and now more and more in person, as we are becoming more part of the integrated teams that are going out to do the ever increasing, unfortunately, number of nursing homes that are seeing an impact from the COVID-19 virus. I think now we've all, probably most of you have it in your area, certainly in the city and Long Island, you have followed very closely behind, and you're living this as we speak. We've learned a couple of best practices. We've developed some papers. We were actually asked by the CDC and New York State to write up our response to the initial nursing home and develop that as a plan to be used across the state and potentially across other states. So we're very proud of that. It's certainly not rocket scientists. It's just something in EMS we do every day. We find a task, we find an incident, we manage it appropriately. We check ourselves at the end, develop a little bit of a best practice, and move on to the next case. Our staff has been overwhelmingly delighted to be involved in this. The folks on our community health side certainly understand the impact, and the EMTs and paramedics that have come over to join the crew are certainly people that, interesting enough, are very single minded and in the future would be perfect candidates for those type of programs. So I think big picture, this is an absolute MIH success. Can't leave it without just a little bit of humor. And being New York, I realize I've flown through this a little bit fast, but I'm sure there's some questions for the end. And I don't know, Jonathan's trying to get back in line. So I wanted to finish up a little early and make sure everybody had a chance to keep pace. I hope that was beneficial.
Thank you so much. That's fantastic. So I wonder if you could comment on some of your previously existing CPMIH programs. I know you do some work with some hospitals in Westchester around readmission prevention and things like that. Would you be able to comment on how those programs have been affected? Are you seeing increases in volumes, decreases in volumes? Are you able to continue business as usual in those programs? What has changed for you?
Well, everything's changed for all of us. Certainly on our community health side, we've tried to impact our patients as little as humanly possible. We've committed to our 2 primary hospital programs that any patient that has any urgent need will be seen in our usual, within our 20 to 30 minute time frame that we've always done. We've increased our telephonic outreach to patients. Everybody is getting touched base with once a day. Anybody that's new to our program is getting their standard, initial response and, and needs assessment. We have 2 patients that were referred to us who actually are under quarantine. So we do have 2 patients we are interacting with that are on the current commissioner's list of quarantine patients. So there has been a decrease in face-to-face visits, and quite frankly, it's been a collaborative with the patients. A lot of them don't want somebody else coming in right now. We are still doing, again, outreach. Our 7-digit number is available. We're seeing all original patients as much as they want to be seen, and so far, all of our recent requests have been seen. So I would say there has definitely been a decrease in face-to-face. There's been an increase in telephonic, but none of our patients have had a request to go without being met as they would have been met during our normal course of business.
Okay, fantastic. Thank you so much, Hanan, for that great presentation. And I'm sure there'll be a lot of robust discussion during the panel session. Hopefully, Jonathan, you're all set on your end?
I believe so. Yes, sir.
All right, fantastic. So I'd like to once again welcome Jonathan Washko. I've already introduced you. So the short version is there's few in our EMS community, in our industry, that know more about EMS than Jonathan Washko. And in particular, I think there might be some opportunities for nurse call triage for during this time with the coronavirus, and of course for ET3 and other things. So look forward to hearing your talk. Thank you.
Thanks, Kevin. Can you see my slides?
Yes, sir.
Okay, great. So good morning, everyone. I appreciate the opportunity here and apologize for our technical snafu earlier. Apple did a security update on me, unfortunately, and didn't realize it. So as you can see in the background, we're a little disheveled here at the Washko house. We've got 3 children trying to scramble to do, schooling at home. And so we're doing our best, as I'm sure many of us are, to be able to adapt as this situation continues. As Kevin said earlier, one of the things I want to do is thank everyone on this call, thank my team at Northwell for adapting and just rising to the occasion of the COVID situation. The amount of teamwork, effort, extra hours that I'm seeing put in by everyone in the industry is just a testament to what we do, as well as our healthcare partners. So let's talk a little bit more about nurse call triage and what it actually is. So there's actually about 3 components associated with this. So there's nurse call triage, nurse navigation or care navigation, and then medical advice. We use the system from the International Academy of Emergency Dispatch called the Emergency Communications Nurse System, which is integrated with our 911 call taking system, which is the Advanced Emergency Medical Dispatch System, again from AMPDS. So we have an integrated system. Like I said, there's basically 3 components to this. There's a triage component, which the EMD system or the AMPDS system allows us to do. So someone calls 911, we go through a screening, and then that screening allows us to risk stratify a patient's needs. Then, and typically we would send an ambulance. The system helps us decide, do we send the ambulance with lights and sirens or not? The system can help you understand, do you need BLS or ALS? The system can help you understand, do you need first response or not? But the newer things that the system can do now is also say, well, this is a lower acuity system. We don't necessarily need to send an ambulance. Let's have the patient talk to a nurse. And that's really what these systems are designed to do, is what's known as 911 de-escalation. These systems can also be used for other things. And we're going to talk about that because we actually don't use it in the traditional sense. We use it in a different sense, and I'm going to quickly go over that. But then talk about, I think, some exciting things we're trying to do here in New York with our collaborative group in New York and the ET3 group with FDNY and Sinai and many of the other hospital systems in New York to try to implement something like this now, even before ET3 provides the NOFO grants and the funding source for it. So what you see in front of you or on the screen at this point was kind of a vision we had many, many years ago. We brought ECNS into our call center back in, I believe it was around 2014. And we've done thousands and thousands of calls through it, but doing it in a different way. We weren't doing it through 911 public access, but we were doing it as a managed care population tool. And as you can see here, we created essentially 2 pathways. So we were in the green and blue pathway since program inception, and these are patients that we tell to not call 911, to call a 7-digit number. Our ECNS system is used to screen it, and then we have the ability to provide all kinds of different endpoints of care to the patient, as you can see on the right. The CNS system was traditionally designed, designed to go through the red-blue pathway, where someone calls 911. There's triage by the Advanced Medical Priority Dispatch System, and based upon, again, acuities, would go to ECNS for additional triage, and then navigation of endpoints of care. And then there's also another interesting opportunity, and this is actually what we propose, or we're going to propose to do to CMS and CMMI, which is the concept of a 911 redirect. And we're going to talk a little bit more about that, because we're actually going to be implementing what you see in front of you here in New York City, hopefully by next Wednesday with Northwell, in addition to also providing telemedicine and telehealth as part of an integrated model, which I'll show you shortly. So on the care management side, very quickly, we use this to manage care populations. Right now we use this mostly for a risk-based cohort, as well as another CMMI demonstration project known as Independence at Home, of which Northwell is, I believe, the top provider in that demonstration project on all accounts and all measures. And a big part of that is the integration of the CCNS system and EMS and community paramedicine in the ability to achieve those results. One of the things that ECNS does, and I think this is the most important part, is it really allows you to risk stratify a patient's needs into basically, I guess you'd call this the magic quadrant, where the horizontal axis is the type of evaluation needed. Can it be done remotely, or does it need to be done in person? And then on the vertical axis, how much time do you have in order to provide that evaluation? Do you have extended time, or do you have less time? And then within the boxes, you see some examples of what are called locuses of care, or recommended care levels, RCL. So the RCL, recommended care level, are the colored boxes. And then what you can do within that recommended care level are just some examples there. And again, we'll show you what we're doing with FDNY as well. So this is an example of some of our work in our managed care population, looking at the initial recommended care levels using low code based upon the initial screening, and then using a combination of nurse advice, nurse call triage, and then provider level services, including hear and treat over the phone with a provider without video, and then a community paramedic response with video in order to integrate or launch telemedicine, so that additional screenings can be done and hopefully safely keep the patient at home and do care plan changes without having to go to the emergency room. So this is a bit busy, but this is what we are planning to do, and this is what we proposed to the Fire Department of New York, and we're, again, all of the voluntary hospitals in New York City, given the pandemic situation, are rising to the occasion to provide all kinds of options to FDNY. We are choosing to go this route, and you look on the left-hand side, you can see FDNY has requested to send 911 calls for medical screening and medical advice and telemedicine and telehealth services, as well as there's callers on the 311 system that need medical attention. And we're going to be implementing Card 36 with the AMPDS system. If you're not familiar with that, that is their pandemic level assessment screening tool, as well as triage tool. We are going to launch this, what's known as triage. We're calling it triage level 2. And you'll see there's some things in here that you don't typically see, and that's because we're literally in a disaster situation. And so we're going to be taking this a little bit differently than it's designed, but I think it's important to share some of the things we're working on. So as these callers come in, low acuity 911 callers come in, if you have AMPDS, you could do this yourself. If you institute Omega or your Alphas and maybe even some Bravos, you triage the caller, and then with card 36, it's really designed around if someone's calling with COVID-like symptoms. If the person's highly acute with severe difficulty, respiratory impact, you can see the card goes, or the caller is sent to EMS with the Delta acuity card on the red box there. If the caller is of low acuity, we are actually going to be implementing paramedic level advice using pre-written protocols as well as chatbots. I know the CDC, if you haven't had a chance, has a really nice screening tool that you can use. Alberta, Canada has a screening tool. There's a couple of various screening tools popping up that you could put in the hands of your paramedics, or probably even an EMT. As we scale out, we would likely go to that if we go to pandemic triage level 3. Which is high levels of triage, so that we can scale. But right now, if we have low acuity, we're going to use paramedics to offer advice. Then you see there's this other pathway. If you go down into the yellow box, this is where the ECNS system comes in, and we're actually going to be sending Charlie level acuity at this triage level. Now, typically we wouldn't do that, right? You would usually send this to the ambulance service, but because of the overwhelming impact to the healthcare system, we have got to do everything we can to bend the curve, as they say, or extend the curve out because of the tsunami that's getting ready to hit the New York City health system. And so there's a tremendous amount of concern over that. And so we're going to have to do everything possible, all hands on deck, to try to keep patients out. And it's going to need to be at a much higher level of acuity than we typically would be used to, again, because of the disaster situation. So as you see there, the yellow box with the dash and 2 dots, that's our ECNS system. We're actually hiring additional nurses and only training them in the pandemic flu-like symptoms, and then any other collateral respiratory type issues associated with COVID, just because the amount of time it takes to get an ECNS nurse qualified for the hundreds of different pathways within the ECNS does take a little bit of time. So we've worked with the academy to get an emergency override to allow us to do short-term training to get these nurses up and running beyond what we already have today. And then you can see the recommended care levels. These are going to be the ones we will be using. So you can see on the green box, there's nurse instructions or self-care. In the blue box, there's a primary care referral. Transfer to our patient access services group, which is a physician scheduling, centralized physician scheduling system, and if necessary, send pre-scheduled community paramedicine. On the bottom right, obviously you can see there's other options for urgent care and emergency room, as well as send an ambulance, or if necessary, they can self-transport. And then finally, you see on the lower left yellow box is the concept of hear and treat and telemedicine. And so this is a unique thing that we're going to be introducing into the system, where as a locus of care, where we can provide either over the phone care or a telemedicine visit with video to a patient from a qualified healthcare practitioner. We're starting with physicians, but eventually we'll scale this, I'm sure, with NPs and PAs. You can see the workflow associated with that. Additionally, if you go back up to the original triage, EMD triage 1 through 32 and 36 in the EIDS screen, we'll also be triaging patients directly to telemedicine. If they fall outside the COVID screening and they aren't a COVID patient, we'll actually be leveraging telemedicine there as well. So we're pretty excited about this. Like I said, I know there's a lot of others in the city of New York that are going to be implementing various types of systems like this, whether they're using their own nurse call triage system or other systems. So because we have our CMMI colleagues on the phone with us, I am kind of asked this group we need a call to action, and that's everybody on the phone. I need you guys to email CMS, CMMI, provide feedback if you agree with me on some of these things. But we need ET3 launched immediately. We need to do it and remove some of the red tape associated with it to be able to launch without the implementation plan and all the contracts that are necessary, because especially for us in New York City, I mean, it's literally hundreds of providers that we have to get contracts with. We'll do it, but let us do it later or defer it, please. I would recommend we open up ET3 to all providers. We really need to think beyond just nurse call triage and allow payment for hear and treat in addition to telemedicine, and again, also to pay for ECNS or nurse call triage, and then implement the NOFO grant program now, as well as let us know what you guys are thinking again for sustainability funding. I really think it's important, especially for this in this situation we're in right now. And we believe we can do this with the waivers already implemented by Medicare, because they have waived telemedicine and telehealth regs that allow us to go direct to consumer patient home for that. So I think we're okay here, but it's a short-term thing, and it was not intended or wasn't originally part of ET3. I really think we should have that as a component within ET3. So basically, give us ET3, but without ambulance requirement on scene. And obviously the payment system would be different for that, but something to think about. The folks at CMS and CMMI know I've asked for this multiple times. I'm going to continue to ask for this to please remove the 911 requirement so that we can apply this in other parts of our community. We're going to do it without funding because it's the right thing to do, but we need to fund it. And then finally, probably my largest concern beyond the pandemic is the economic tsunami that will ensue 90 to 120 days from now. We're seeing tremendous drop off in volume, as I hear others are, which is somewhat to be expected. And that's why I'm hoping to repurpose what we do into the system I just talked about with community paramedicine and these types of things to hopefully get volume to have economic sustainability. But I'm very, very concerned about the ambulance agencies that are somewhat independent, that may not have much of a cash reserve, that aren't going to be able to pay their providers, if their volume drops and they're unable to bill. I mean, we also have to think about that. We're fortunate, we decompressed our 911 center in our administrative building, and we have most of our billers working at home, and they're still able to bill. But I'm sure there's EMS providers out there that may not have that capability to keep their billing systems flowing while also reducing the workforce and meeting the requirements of mandatory quarantines and things like that. So I'll stop there. And again, thank you for the opportunity. Everybody, please be safe and well.
Thank you so much, Jonathan. That was fantastic. And I did not know you were going to make such a call to action. I certainly, I've typed into the chat encouraging others to comment on your call to action so we can get a sense of the audience. It's always, a little different in a webinar setting. We can't read the room quite as well. So I really appreciate if folks can make some comments so we all know how everyone's hearing this. I think we have, Jonathan, I'm sure there are a lot of questions. First of all, yes, Mount Sinai and others are planning to participate with FDNY, but clearly, your level of sophistication and preparing for this has been immense. And I wonder if you would be willing to share that framework, that flow diagram, which was incredibly detailed, incredibly full of amazing tidbits with the rest of us who are not quite as smart as you.
I wouldn't say that, but absolutely, we're happy to share. I'm working on trying to put another webinar together just on this with EMS World. We want to get this out to everybody, obviously, and we need to share it because we all need to come together in response to this. So absolutely.
All right, fantastic. I am going to introduce our last speaker, and then we'll have some Q&A time for the panel. We're really pleased and honored to have the director of the Bureau of EMS here in New York State, Ryan Greenburg, who's going to be giving us a little bit of the lay of the land of, well, at least his intended talk long before COVID was talking about MIH in New York State. And today, we're eager to kind of get his thoughts on whatever is top of mind. I can't imagine what that would be. But just to give a little more background on Ryan, he spent nearly 20 years working in EMS. He's been an EMT, risen to a chief of EMS for an agency. He's focused his career on building hospital-based EMS systems across the Northeast, while always remaining an active paramedic. He's an educator, an EMS advocate. He did his undergraduate degree from Babson College, master's degree from Seton Hall University, and postgraduate from Columbia. He's on the executive committee of the board of directors of the National EMS Management Association, NYMH, and is a fellow of the American College of Paramedic Executives. So you've been director now for what? Has it been 2 years?
Just about 2 years. April makes
just about
2
2
years.
years. Fantastic. And I think you've brought I think a lot of energy to the office, and we've been grateful to have you last year. I think you've helped me and others better understand what we can and can't do with regards to innovative models of EMS. I know I can't say the magic word that's initial. The abbreviation is CP, but I'm not going to say that. But
community paramedicine, I can say it this week. It's in the executive order. So
yeah. Oh, good. So you've given us a lot of guidance over the years, and really appreciate you being here with us today. And so please, give us your thoughts on NIH, on COVID, CP, how we put it all together. What can we do in New York State to all work together to help this state of emergency?
Yeah. So welcome everyone. Thank you, by the way, for taking the time to be part of this and for giving me a few minutes to speak. I will try and keep it fairly brief, and then obviously take any questions that people have if there's time permitting. So I will tell you, up until literally about 20 minutes ago, I didn't know if I was going to even be able to make the call. We have obviously a couple things going on at the state and with everybody. And so to everybody who's on the call and the providers and Empress, who's just out there doing a phenomenal job. That's all the providers, but in addition, Empress. Thank you for everything that you're doing in the middle of this. There's obviously a lot of just unknowns going on, and things are changing at a very rapid pace. So from the Bureau of EMS and the Department of Health, thank you for everything that you're doing. So jumping a little bit on going backwards, like Kevin said, I've been here about 2 years, and it's been great. We've had a really exciting time with the Bureau, and we've seen a lot of things be able to start to take traction and move. And part of that is just aligning the right time. Things lined up, the sun, the moon, and the earth, we were good. And we've started to move that progress forward. And so we're excited to see that. And so things may not be moving as fast as we maybe always want it to, but we're really starting to see a lot of movement on different things. And one of the big things from the Bureau that we're saying is just because that's the way we've always done it doesn't mean that's the way that we're going to do it going into the future. And we're not just talking about NIH there, but we are talking about whether it be how we provide EMS services, what our providers can do, expanding the way that we teach our providers and just education. These are things that, we've done it a certain way for many years and it's worked, but couldn't we do it better? Can we do it differently? And so we're really starting to advance that mindset and advance that. And as a Bureau, we're saying, okay, if you have ideas, you have concepts, you have different things that, maybe before didn't work, well, let's bring those forward. And so the biggest thing that I can say is, please, as these ideas come up for NIH and these ideas come up for whatever you're working, or what Chief Washko was just talking about with ET3 and telemedicine and what's going on in call centers, they're different and it's foreign, but they can really make an impact on a system. So we're pretty fortunate in New York. When ET3 came about, the Bureau took a pretty solid look at it as well. We have 25 agencies statewide that were selected, 15 of them in New York City. But that gives us a statewide presence on this. And so we did a lot of work on our side to make sure it fell within regulations, it fell within the guidelines and statutes, and we had to make some changes on a couple of things, nothing that big to allow ET3 to happen. But the biggest excitement for me, both as a provider and a paramedic who still sits in front of the ambulance, as well as the system overall, is, currently today, we really have two options when it comes to treating a patient and then or when we go to a house. And so we can either RMA them or we can take them to the ER. And we know that those may not be the best options, but those are the only options we have in EMS today. And so when the ET3 model came out, our ability to look at it, our ability to look at these options really became something super exciting and something that we see tremendous value in a multitude of ways. Our agencies, the healthcare system, kind of across many, many things. So we took a strong look at it. Like I said, we had to update some protocols, look at some regs and some statutes, and to make sure that it all fell in line, and all things considering it does. So that's super exciting. And ET3 for the 25 providers who it was selected for, was good to go. Obviously now, fast forward a little bit more, and the COVID crisis comes around, and we start now looking at, okay, well, this is in the middle. What if things have to start to change? What can we do? And rather than have to rewrite the book at the start of it, we've been able to look and say, well, a lot of what we could do, should we need to get to this point, is ET3. It's the model. It's what we've done. So when we're asked, well, can we do that by reg? Can we do that by statute? Yes, we can. Do we have a playbook for it? Yes, we do. So that's a really exciting thing to have happen, just the domino effect and where things lined up to being able to look at that a while ago when things were much more calm. But now when this is going on, turn and saying, hey, here's a toolbox that we can use. And now we got to figure out. And by the way, I would agree with Brent Myers on this one in saying I have no surprise. There's no surprise that Chief Washko had a call out there and asking for support, and I understand and respect it. But reality is that there's a toolbox there and there's a skill set that maybe can be used immediately, that maybe could be used by more than just what was originally picked for ET3. And those are things that everybody needs to look at when we're looking at all these options. So that's it, to be in such a place and to see possibly whether it be on a small change just for the 25 agencies, which obviously encompasses the bulk of New York City, or the big side of things of being able to roll it out statewide. It's exciting to at least have that option that's there, or at least know that's it's not foreign. We're not writing it from scratch. There's a ton of time and effort that was put into that development, and it really could affect how we handle both this and kind of where we look. And when I'm out there and I think 5-10 years from now, what does the EMS system look like? I don't think it looks like what it does today. I think it is much more. We become the further extenders of healthcare services. We truly are the healthcare professionals that are out in the field, on a pre-hospital and just starting to expand that toolbox. We've continued to expand the toolbox, both for paramedics and EMTs, in what they can do, in the medications they can give, and in all these things. And I think the next step in that will be, what the options are that they can do. That it won't just be you can RMA a patient or you can take a patient to hospital. And in many cases in the future, it may be, hey, that community paramedic is coming to see you, and it's to help you with your discharge management or that gap period or so on and so forth. So from the state side, it's exciting to be looking at those things and not only to be looking at those things in a simple way, but looking at those things and saying, okay, there's a model behind this, there's a structure to it, there's sustainability models to it, which is equally as important to us. So at the same time, and obviously right before COVID and everything else was going on, there's different initiatives going on at the state for to help the state and budgets and different things like that. And so just the questions that I got from different agencies and things that were about ET3, from a cost savings point of view, hey, can you submit it? And obviously we turn and say you can submit whatever you want. But just again, just that collaboration of people thinking outside the box and saying, here's the innovation, here's something that's different that we can really think can save money, that can help our patients, that can keep them in the right place. That's what we're looking to do and to move forward. And I can tell you that you have a tremendous support from the Bureau in regards to taking those ideas, taking those concepts and moving them forward. The important part, and I guess the part that I would say that we don't always talk about as often, or I don't hear about it as often, is quality metrics. So for the first time in January, with NEMSIS 3 data, we set out and we put in place 6 state quality metrics. And those are quality metrics for standard EMS calls, and we're happy to share those with you. They're public documents that came out from the CMAC and SEMSCO. They were created in collaboration with the CMAC, with our docs, and they start to measure quality. They start to look at things and say, hey, here's, how can we improve, what are different things in our agencies that we can do better? And some people said to us, well, what's the benchmark? What do we put in? And I said, well, the benchmark really in the beginning should be about an individual agency. So it should be about turning and saying, well, if my agency, and I'll just go to ROSC for a second, if my agency, gets 27% ROSC on our cardiac arrest, wow, great. Okay, how do I get to 28? Or if my agency is only at 7% ROSC, okay, great. How do I get to 8 or 9% ROSC? So why do I put it that way? I put it that way from the point of view of whatever it is that you're looking, at least you're starting to look at a metrics and move that metrics up or move it to better. Also, I may turn and say, hey, how do I go to Washko and say, how is your agency at 29% ROSC? What are we doing wrong? And he may turn and say it's the dynamics of location or transport time or how close a hospital is. Never know. So also working with agencies that are similar to yourselves. So why do I bring that up? I bring that up because the next step in that is, as we look at these models, as we look at ET3, as we look at community paramedicine, as we look at whatever it is, one of the biggest questions that I get asked is, well, how are you going to measure it? How are you going to look at it? How are you going to know that it has an effect? And that's something that I think, particularly this group, needs to turn as a group and say, okay, well, if we're going to do this, what are some quality metrics that not just one agency is looking at, but the group is looking at as a whole, so that we can turn and say, here's the differences that we're seeing, and we're not just seeing it in Northwell, or we're not just seeing it in Mount Sinai, or we're not just seeing it in Empress, or we're not just seeing it in Brighton, or whatever that side might be, but we're seeing it collaboratively across. Or again, going back to saying, hey, Brighton EMS, who's up in the Rochester area, they're knocking the cover off the ball with readmissions, and we're not really sure why. Let's find out. And is that because of patient demographics? Is that because of a program they're using with telemedicine? Let's work together. But I will tell you that those metrics and that ability to turn and actually measure things and be able to turn and say, here, I've seen, we're monitoring these 50 patients, and these 50 patients, we're trending to be in the ER another 10 times in the next 90 days, and all of a sudden they're not. They're there twice or none. Those are the things that really start to turn and say, and help us at the state turn and say, okay, yeah, we need to expand this. We need to look at it further. We need to, take it to the next step, because here's measurable data to, right from things. And it's not from good, bad, or indifferent, another state. It's not from another region. It's from within the Empire State. It's from within what we're doing. It's our people who we're helping, and here's the actual facts and the data. So with that, I know we're a little short on time, so I'm going to cut out there. Again, thank you for everyone who's working on and doing an amazing job with the COVID response. Thank you to everybody who's thinking outside the box. I will tell you flat out, if you don't know me, if you've never met me before, by all means, feel free to reach out. My email and everything is not on the screen, but we'll get that up there. I love new ideas. I love to hear it. I have no problem telling somebody, hey, that's a really, really far stretch. So it's good, but it's really far away. I also have no problem saying, oh, it's a really good idea. Let's work on expanding it. And I love, kind of sometimes partnering people. So turning and saying, hey, that's a really good idea. Why don't you go speak to Kevin, or why don't you go speak to Jonathan, or why don't you go speak to this person over there, and both, whether it be in state, out of state, to help formulate those ideas and get them to the next level. If there's anything at the state that we can do, please reach out. Please be a little bit understanding at the current moment, as we are all stretched a little bit thin. So our bandwidth is challenging, but it doesn't mean that we don't want to hear from you, particularly when it comes to innovation ideas, and particularly during this time where some of those innovation ideas really can play a very, very active role on how we respond and what we do, and moving forward and shaping that. So with that, I will stop talking and see if anybody has any questions.
Oh, thank you so much, Ryan. That was fantastic. There are a couple of questions. In the meantime, I want all of our panelists to kind of maybe turn on their cameras as we kind of gradually shift into panel mode. But a couple of questions for you. Could you comment on the Medicaid redesign team? The second version voted to submit a proposal to the governor yesterday to expand the EMT scope of practice to include non-emergency situations. Question from Isaac Sobel. What are the potential non-emergency scenarios that we can put forth to build out this concept. And I'll just tack on to that. Could you reiterate exactly what it is that you see as that has been specifically enabled either by DOH directly or by other kind of state actions in this moment of crisis, state or national actions?
So I will. So we'll start with the first part in the Medicare, the MRT team. So they're working a lot, and I got to be honest, we in the midst of the crisis have not been on all the calls, been able to watch everything to see exactly what they were talking about or expanding things. But the biggest thing that comes up in what we hear is that the way EMS is designed in New York is predominantly for emergencies, and so a lot of that looks at as we look to expand and do more things is to further expand what we do and taking it outside of that emergency world. And so better clarification, definitions, and things of that nature to expand where we are. And there's, obviously a lot of interpretation that goes along with that. So that's in regards to that. I will say, from what I heard, and again, it's a lot of just reading and watching, similar things to what you do. Everybody here is that, there was a pretty strong response from EMS and a pretty collaborated one, it sounded like, from the messages going out. And so that was, nice to see and hear. And so I can't stress enough the importance of a collaborated voice, the importance of not having a broken message go out, because it becomes very, very difficult, even within the Bureau, in trying to help move EMS forward when, everybody wants a slightly different path to take. And we're trying to say, hey, we're trying to, drive a ship down the road here. If everybody wants us to go in different directions, it becomes very difficult. So that's that part. So in regards to the crisis and what's going on, there's a number of executive orders that are in the works, and then they're out there to work with us and help us adapt to this change and deal with some of the things that are going on. Everything from things that aren't that simple, but are certification periods. Our abilities to test right now have been restricted. Our abilities to bring people in for PSCs are restricted. So, we're looking at a lot of that from that dynamics, and some of those executive orders work on that. Some of the executive orders work on bigger pictures, but I'll hold off on saying anything too much right now until we know from our side kind of where that is. But, one of the things that I will mention, and, very, very public, is, we have stood up a number of swabbing centers throughout the state. And, we have different providers who are there, servicing, working in those, both in the drive-through centers as well as home visits. And they've looked at EMS, and they've looked at EMS from day one, both in the Bureau and outside the Bureau, as clinical professionals who can help with this process. So one of the EOs that came out allowed paramedics and EMS providers to perform that skill with the commissioner's approval, with appropriate training in sight. So just the fact that they're, that we're again being recognized as that healthcare professional that can do these different things is exciting stuff that's there.
Fantastic, thank you so much. And that is remarkable. I want to remind everyone out there in the webinar that you can type in your questions in the Q&A. I have a number of questions left over from all the great talks that we've had, so I'll start with some of those. Question, I'll start with Brenda, but I guess others can comment as well. A question from Stephen Blocker: what protocol changes at the agency regional level are you expecting to see for the paramedic and EMT? And I'll kind of tag on to that question, another question from Staley Dietrich, who, by the way, I have to thank, who helped tremendously with this conference, mentions that because it's, ET3 is such a big change for EMS, it's also a big change for EMS training. And, what do you see in terms of the training that you think is necessary, and others can comment as well. And then from the state perspective, what can the Bureau of EMS do to kind of support those training needs to make ET3, more palatable?
Thank you, Kevin. Can you hear me?
Yes, loud and clear.
Great. So the structure of the ET3 model as communicated in the request for application and as articulated also in the participant agreement requires compliance with all local, state, and federal laws, statutes, regulations, etc. So the model requires compliance with those structures. Then, as I said earlier, the protocols will be developed by individual participants, and those protocols will need to be approved by their medical director, and then, of course, similarly, by any sort of, medical control boards or medical infrastructure, governance structures within local areas and states. So I want to emphasize that the ET3 model fits within that structure. Once those protocols are built, then training comes next. So those training programs would adapt to what is the service that's provided, and of course, what are those protocols that are developed. There are a few places in the ET3 model, as communicated in the participant agreement, that do have specific requirements. And those requirements, I would generally say, are associated with the scope of practice infrastructure of existing EMT, paramedic, nursing, and qualified healthcare practitioner levels of care. And I'll answer it in that general way.
Okay, thank you. Ryan, do you want to comment on the state in terms of supporting training? EMTs are and medics are now going to be deciding if a patient needs to go to the hospital. What do you think are the training needs, and how can the state BRVMS support?
Yeah, so from a training point of view, I mean, there's definitely a large portion of this that we leave at the local medical director point of view and the regions, regional protocols, because we do think that these calls, and as we start to adapt, do have to have more of a collaboration with those medical directors and consult. And I think Jonathan was talking before about algorithms and thought process and in kind of some things and similar to our current protocols and running a cardiac arrest. And so some of our patients will be fairly easy to navigate through, and some of our patients will be more complex. From a training point of view, that at this point we're leaving up to the individual agencies and how they want to deploy that and what they want to look at. We haven't looked at anything from a state training aspect or certification at this point, because with the ET3 model and what we're looking at is a lot of it's the skill and the scope that they already have. It's just taking it and using it in a different fashion than what they've been doing before, and maybe taking that iPad and incorporating a physician who may turn and say, okay, we'll check lung sounds, can you send me the 12 lead, can you do these things? These are skills that they know today. These are skills that they can do today. That it doesn't really change that much of that training on that part versus the training on the technology, the collaboration. And I would even go as far as saying we've been collaborating for a long time. We call our medical directors, on a regular basis when we have a complex case or something's going on. So that shouldn't be that far. And I'd probably say it's probably a bigger step maybe for our EMTs and our paramedics, just because they don't have that same interaction or that same regular interaction with our medical team. But outside of that, we really think it's a pretty short jump.
Fantastic. I want to bring Brent Myers into the conversation. A question that was left over from your presentation, but really, I think maybe a philosophical question. And as somebody who's a sort of a visionary and thought leader in the space, you can help. A question came in about are there plans for more on-scene autonomy for paramedics in transport decision making? Meaning, ET3. I guess there's a lot of autonomy. It's protocol driven here in New York, at least, and telehealth is more with a qualified healthcare practitioner. But just generally speaking, do you see this going more of a direction of kind of extensions and collaborations with other providers in the healthcare system, or do you see us growing this more in the paramedics' hands, in their scope of practice, to be making a lot more decision making in the field without further assistance?
Sure, thanks for that. A couple of reflections. The first, we've already talked about training, right? We have constantly put paramedics in positions to ask them to make decisions without any prior education, and then become surprised when they didn't work as well as perhaps they should have. So there's nothing that a paramedic could not do within a scope, so long as there's appropriate education in the background. So I think that's an important fundamental piece that we need to make sure we don't overlook. That being said, I'm probably going to say some things that Brenda can't say, which is that from an ET3 perspective, this is a Medicare policy and protocol and pilot program, right? And so Medicare beneficiaries today have the right to encounter a provider. Now, we can argue about the definition of provider all day, but you can't change the definition of provider in a pilot program. That just doesn't work. So this notion that it's pejorative about having to go through telemedicine or what have you is a falsehood. It is simply, we've gone as far as you can in a pilot program, and there's got to be a different mechanism if you want to make that decision separate and aside from encountering a provider. So don't throw ET3 under the bus for doing the most they could under a pilot program. So those two caveats, then we can say that certainly paramedics will be making these decisions more independently. And my prediction would be that our private payers will be able to reimburse that more quickly, perhaps, than CMS can. So you could see, and we've already seen some of this with Anthem and elsewhere, where people can come in and do this kind of thing already with the appropriate education. So yes, that's a long way of coming to answer your question. Absolutely, paramedics have more independent decision making, but there are some structural things that it just takes some time to change that are beyond the scope of any individual projects. And Jonathan is dying to jump in here and either attack or maybe for once, endorse it. We'll see. It'll make a conversation.
No, absolutely endorse. I mean, here's how I look at it. Look at the evolution of EMS, going back to the 1960s, right? We started, Johnny and Roy is a great example. They were trained, they were credentialed, but they weren't allowed to do anything without getting permission from a physician. Telemedicine, right? ET3. That's what it is back in the 1960s. Slightly different mechanism. We didn't have video, some of these other things, but that's exactly what happened. Then look what happened over time. We iteratively started to allow paramedics to do things more autonomously and on their own. And I think basically that's what we're seeing here. This is a restart. Life is always cyclical, right? So in my mind, this is, the beginning. We're going back to 1960, back to Johnny and Roy, but in a whole new way of how do we take what the skills and capabilities of a paramedic are and change the way we deliver medicine, be seen as medical providers instead of technicians or as, transportation commodities, and leverage, I think, clearly what our medical capabilities are in the home. And that's going to take time. And that's why we didn't try to go to that expanded scope model immediately. We wanted to use the physicians. Our paramedics are not allowed to do anything autonomously other than an assessment and vital signs and things like that. And it's a 100% dictated online medical control model, which has allowed us to really have some amazing results in terms of keeping people safely at home and driving down the cost of healthcare while also improving the quality of lives of these individuals and their caretakers.
Could I just add one reinforcing comment? And Ryan, you should go next, and then go ahead, Ryan.
I'm actually just going to say goodbye because I have to jump onto another one, so I apologize. But thank you for the opportunity, everyone, to be here today. I apologize that I can't stay longer, and I wish you all the best of success. And please stay in touch. And Kevin, please make sure to share my email.
Will do. Thank you.
Thanks, Ryan.
Have a good one, everyone.
Brenda, go ahead.
I was just going to add that as the pilot program builds the evidence base, and as programs outside of the ET3 model build the evidence base, and as more research is published, that is obviously how these models scale. So I noticed there were a couple of questions in the Q&A about when and how do these models go beyond the current pilot. That's how. That's a simple answer, but that is a broad responsibility of all of our industry and the 205 applicants to build that evidence base.
Thank you. So I'm going to try to share my screen and kind of go through some final thoughts, but I encourage all the panelists to kind of stay on. I know we're kind of right at the end of time. So if we're able to kind of keep you on for a few more minutes in case anyone has any questions as we go over the time, they can do that. So I am doing my best here. Okay, control. No, escape. Again, we've come a long way nationally and locally. Everyone can hear me? Okay. We've come a long way nationally and locally here in New York State. We're really proud to have 9 CPMIH programs. We've learned a lot from each other, learned a lot from all the speakers today, from CMI, from other parts of the country. I'm hopeful that there are some folks out there listening that can take some of this information and actually help get some new programs. We get some more stars on the board for next year. Again, nymih, New York Mobile Integrated Healthcare Association, is a statewide coalition to try to connect all the different stakeholders in EMS together to kind of advance opportunities for EMS. Our goal is to kind of help sustain existing pilots and spread them and try to take them to scale. And this is a slide I borrowed from Brenda a long time ago. In case you're out there and there's a barrier that's holding you back, please take a look at this document that's available at emsinnovations.org. It has over 250 recommendations to help at the agency level, the city, the state, national level, to try to help overcome barriers to innovation, and it's a worthwhile document to take a look at. I also want to acknowledge there was a question that came in that I didn't get a chance to answer from Chris Hansen, but he's been involved in helping put together the MIHCP Learning in Action Network, which is available at this website, supported by TMF, which is a CMS quality improvement organization. These organizations exist as sort of partners with CMS to help improve care. Their metrics are often our quality metrics, and they often have funds available to try to help support local programs. And in particular, TMF is really interested in supporting CPMIH. In this time of COVID, there are a number of things being taken, put on the table as ideas for innovation. A lot of regulation, there's a lot of deregulation that's happening to try to help healthcare in general. And EMS is definitely a part of that and can take advantage. For example, I know telehealth is now able to be provided by a physician in any state to all 50 states. And I know that there's a lot of additional reimbursement. You no longer need to be, the originating site no longer needs to be in a healthcare facility. So basically, if EMS were to do telehealth with a healthcare provider, that healthcare provider could bill for it. That doesn't solve the EMS piece, but that is helpful. And I also wanted to kind of close with a little bit of a special announcement that New York Presbyterian, the newest, or at least the one of the stars we added this year, has partnered with Mount Sinai and applied and actually received a large grant from the Patient-Centered Outcomes Research Institute. We will be together performing a randomized controlled trial on a post-discharge community paramedicine program for patients with congestive heart failure. So I want to thank our partners at New York Presbyterian and all the folks at Sinai for helping support that, and of course, Bakori. We're super excited about that and hope that there are great things that will come out of that. I do want to give one more thank you to our sponsors who again have stuck with us despite the changes in plans that have been necessitated by the current pandemic. They are all really great companies that have been generous with their time and resources to help support us today, and for the in-person conference that we hope is coming soon. So again, please join us next time. We hope hopefully in person at the I still wrote web on there. I apologize. At the New York Mobile Integrated Healthcare Conference. Again, thank you so much. Our panelists are still on the phone. I know a lot of people have to jump off, but we will, however long there's folks willing to stay, we can take a few more, can try to do a few more questions.
And Kevin, unfortunately, I've got to run to the next call. I've got them holding. So thanks, everybody.
Thank you so much.
And Kevin, same. This is Brenda Staffan. Thank you very much for the invitation. Have a great day and be safe.
No problem. Thank you, everyone. Okay, there were a couple of more questions that came in. In particular, there was a question kind of aimed at Ryan Greenburg, who's no longer here, but asking what specifically can be done to kind of advance ET3 here in the state. And Jonathan, that was one of your calls to action. I know Hanan, you emailed about this in the last few days as well. What can we do collectively to try to support, try to get ET3 going at the state level, get Medicaid to reimburse for it?
Yeah, I mean, I think the waivers that are coming out for Medicare are also for Medicaid, from what I'm seeing for the most part. We know New York State, when we put our ET3 application together, was very supportive and offered all of us in the state a letter of support from the payment perspective side. So I think the call to action to CMS and CMMI would be the same to the state Medicaid office, to try to open up funding for some of these innovative and alternative ways of providing care, especially in the situation with COVID. So.
Yeah, completely agree. As well as the Healthcare Providers Association and all the private payers, where might even be a potentially simpler. I know there's a lot of talk going on about it. I think we need a large, unified, and loud voice.
All right, we're going to go ahead and unmute the audience from our end. If anyone would like to ask their questions, but just please keep your phone on mute if you are not speaking. A question for Jonathan and Hanan: are either of you successfully billing for the A0998, the treat no transport code that exists, that I know is paid for in a number of states, and Anthem in particular is paying for here in New York State?
Very limited. After the second, interactions with Anthem, we revisited it and developed a new filter to try and capture those patients that fit. So just in the last few weeks, yes, it's a slow start. We do have a respectable population, but then again, as a sum of the whole, it's going to be very small. So having others join in and realize, the innovation of a large insurer could be moved to more small local insurers would be exponentially beneficial.
And how about you, Jonathan?
We've been monitoring it very closely. We actually went and looked at our payer mix to see what the impact would be, and it's pretty much the same. It's very limited. I believe we've started to talk about doing a couple of test balloon claims to see what would happen. But we're definitely gearing up for ET3 to be able to do this. Our care management organization that negotiates all of our contracts is 110% supportive of wanting to change the payer landscape on the commercial side as we move this forward. And so I'm optimistic about the reimbursement piece of this. I think it opens up quite a few opportunities. And again, if we can, a couple of just minor tweaks with things in terms of reimbursement on the telephonic medicine side, telemedicine, telehealth, whether we're doing it in the 911 center, in the back of an ambulance, or in the patient's home, and hopefully expansion, as I mentioned earlier, beyond the 911 call to maybe certified medical communication centers, so that way there's not fraud and abuse and everybody jumps in on it. But organizations like ourselves at Northwell, who are not official 911 centers, yet we do 911 calls. We don't receive, an Annie Alley dump to us, but we also get 7-digit calls where they didn't call 911, but they're emergencies in people's homes. So, I'm going to continue to really kind of push on CMMI and CMS on that, as well as I really think, the telemedicine piece and it's going to take time for us to get the technology and the video out as part of ET3. And so the ability to do a telephonic based treat in place and still be allowed to get reimbursed for is another thing I'm still going to continue to push on. I tried to push on it before ET3 came out. I'm going to continue to push on it now because I think there's obviously tremendous value, and not everyone's going to have the technical capabilities, especially in the beginning, to do that. So,
I think it's interesting that the codes that we're going to use for treat and place, I believe, if I understand correctly, ultimately going to be the same transport codes that were part of, are part of standard transport with perhaps with a modifier, as opposed to using the A0998 code or some originating site code. I don't know if I think maybe Adam O'Best from Medicare is still on the line, so feel free to comment. But for anyone to comment on, is that going to be a problem or complicate things from a coding perspective if you're trying to work with multiple payers, for Anthem being one, to try to manage that seamlessly?
From our perspective, I think it'll be fine. I believe it's just going to be modifiers for the destination, I believe, and initiating location and destination modifier. So I think actually it's good for us. One of the things I'd like to see in the reimbursement system as it gets iterated is getting reimbursed for time. So I know that they said there's no mileage, but we could take the exact same mileage codes and turn that into time. And that's actually how we bill our current community paramedic program. Is we have a base rate just like CMS does, and then instead of billing mileage, we build for any time over an hour in 15-minute increments. And the current billing systems could handle that. So that's one of the things I'd like to see, as we move forward and this iterates, to be able to open that option up, because these calls do take a little bit longer and can take a little bit longer than a normal EMS call, especially if you want to do the right thing for the patient and do a care plan change and actually like what we do. We don't do low acuity calls, we do high acuity calls. So we're starting IVs, we're giving medications in the home, and then we're staying there to see what the what the response to those treatments are. So we can have calls that go 2 hours long, and obviously a single base rate is not going to cover that. So that would be one of the things I'd look to ask people to think about. But in terms of getting it to be able to the as ET3 is currently structured and framed, I think it's fine for us.
Thank you. We're just going to go till 11:15 as sort of that little the walk-up session after the conference where the speakers are available at the front of the room. So if anyone does have any last question, we can try to take one more. But the question that I think has been on my mind certainly is that with COVID, what is the overall benefits versus risks of sending our community paramedics into locations to treat people in the home? Are we is it obviously there's a lot of positives. We can keep people in the home. You can bring care to them. On the flip side, we're often putting our best resources, our most experienced medics, into a potential exposure, and of course, there's some PPE burn. Do either of you have any thoughts on that? I'm sure you're both kind of thinking about those types of programs.
Well, we've certainly seen the PPE burn across the spectrum, as well as the drop off in other calls. Just from a personal perspective, if the people through our telephonic interface with folks, we've been trying to keep them to the more acute responses, and in doing so, if one community paramedic on a single unit response can resolve the situation and treat and navigate the patient home or back to another physician, healthcare practitioner, or telehealth, we've exposed less people than if that person stayed another couple hours, tripped the 911 system, had a full-scale response, and wound up in an ER. So at this point in time, that's kind of my and our perspective on it. Update at 11, but for now and for the foreseeable future, that's how our responses will take place.
Okay, Jonathan.
Yeah, I agree with that. Having single provider go into the home, that was brought up actually on one of our workplace messages at Northwell, and we're looking at that to reduce exposure, reduce PPE burn. I also think that there's an opportunity with the technology. So especially for more elderly patients, we have a program that we call the MTT program, which is a new pilot we're doing, which is essentially a mobile telemedicine technician, and it's an EMT going into the home on a pre-scheduled basis with an iPad to facilitate a video visit for the patient. And so there could be an interesting opportunity with something like that, where we take the technology and just kind of like what DoorDash is doing and putting it on the door and walking away. We could have the technology ready to go, set it there, and walk away, let somebody grab the iPad, go in. I mean, there's some unique things we could think about doing like that, especially for the technically challenged population, of which we believe that, well, we know by experience there's a lot of in trying to do a in-home telemedicine program. So.
Okay, great. So I think we're at about time. There was a comment in the chat from Adam Obest from the CMI ET3 team encouraging people to email the model team at et3model@cms.hhs.gov. In particular, he says anything sent in relationship to the current pandemic will be helpful for CMI and CMS leadership in making decisions about the model. So I think that's a pretty good note to end on. So really appreciate everyone's time today, your participation. Again, this was sort of a brief version of the overall program that we hope to put together for you, and we are still hopeful that we can put together an in-person conference at some point later in the year. Don't want to make any specific plans until the situation has resolved. But again, I think this has been fantastic. Thank you to our speakers. The knowledge that you have shared with us today is tremendous, and you're all thought leaders in this space. And we look forward to continuing to promote the great work you do through the New York Mobile Integrated Healthcare Association. And here at Mount Sinai, we've stood up an academic division of EMS and are looking to absolutely be good collaborators with all of the programs in New York, but also beyond. So again, thank you to all who've attended, and you can always reach out to us and probably to any of our speakers, I'm sure. But my email is Kevin, KEVIN.Munjal, MUNJAL @mountsinai.org, which I'll type in the chat box. And I look forward to next time. So thank you all so much.
Thank you, Dr. Munjal.
Thank you.
Yeah.